and of wonderful moderators to introduce us. I had the pleasure to work with most of the moderators. Some of them were actually my supervisors, like Dr. Safa Al-Muneza, and some of them collaborated in a lot of international events like Dr. Jubara Alallah and my wonderful colleague, Dr. Hanifi Soilo. We have been working together for almost 10 years now, and we did a lot of workshops and educational events in Turkey since 2015 until now. And actually, my presentation will include some of the echo studies done by Dr. Hanifi while he completed his fellowship in hemodynamics and echo in Manitoba. So let me start. And let me know if you can see the screen.
Yes, we can.
Okay, wonderful. So the title of this presentation, Preoperative Cardiovascular Care of Congenital Diaphragmatic Hernia. So I will be focusing on cardiovascular care. There's another presentation for Dr. Ruben Alvaro, will be focusing on respiratory care in congenital diaphragmatic hernia. So just to show you some pictures from our hospital, it is a state-of-the-art women's hospital in Canada. It is a family integrated care hospital when you have just single rooms for babies or the space for family to stay anytime and even overnight. And my disclosure for today, I have to disclose that I'm a consultant with Mallinckrodt, which is the main provider for nitric oxide in North America and Europe. And I have received many unrestricted grants to support research and educational events from the same company. So in my presentation today, I have two main objectives, and I call it as a promise. Promise from me that you will get at the end of this presentation the objectives, and also promise from you that you will pay attention and it will give me full attention, because each slide is based on the previous information or slide. So it is series of information from the basic physiology up to the bedside management related to congenital diaphragmatic hernia. So my promise today, at the end of this presentation, you will be able to demonstrate the pathophysiology and the phenotypes of pulmonary hypertension and congenital diaphragmatic hernia. Second, demonstrate the preoperative cardiovascular management with case scenarios. Just to start with the physiology, the main aim of optimizing the cardiovascular care in any sick patient to optimize oxygen delivery. So that's our ultimate goal, to maintain oxygen delivery. And with infant with congenital diaphragmatic hernia, that could be a respiratory related issue or cardiovascular issue. So it could be hypoxemia or hypoxia. So everything related to oxygen. And let me use a laser pointer. And with hypoxemia, it could be one of the following issues or pathophysiologic mechanisms: limited diffusion because of the thickening of the alveolar capillary membrane secondary to hypoplasia of the lung. You may have issue with the oxygen or gas exchange. You may have right to left shunt, which could be intrapulmonary due to significant collapse or consolidation of the lung. It could be hypoventilation if you are unable to optimize lung inflation. It could be pulmonary congestion in some situation when you have pulmonary overcirculation, especially if the case is associated with other congenital heart disease like large VSD, for example. It could be pulmonary hypertension with high pulmonary vascular resistance, limiting the pulmonary circulation and associated with a significant pulmonary vasoconstriction. It could be VQ mismatch, which is typically the most pathophysiologic mechanism expected in any infant with congenital diaphragmatic hernia. You have a space-occupying lesion which might affect the lung inflation. So we have mismatch between the ventilation and perfusion. So we need to know exactly which one is more prominent, and we need to target our management to the mechanism. Or it could be hypoxia secondary to cardiovascular issue, or an optimized hemoglobin with anemia. So with hypoxia, we may expect low preload due to inadequate filling of the heart, or low preload, low systemic vascular resistance with the hypotensive shock. It could be high afterload with high pulmonary vascular, high systemic vascular resistance, poor myocardial performance. It could be right ventricle or both ventricles, or it could be left-right shunt in some situations. If we use too much pulmonary vasodilators, and shunt might be left-right instead of right-to-left. In all cases, we have one of the three main presentations: hypoxemia, acidosis, systemic hypoperfusion. It is non-specific. If you rely only on the clinical assessment, you may get to understand what the underlying pathophysiologic mechanism. So in congenital rheumatic hernia, we have either pulmonary related issue or cardiovascular. In pulmonary related issue, it could be pathology secondary to lung hypoplasia, surfactant deficiency, or single lung ventilation. So we need to adjust our ventilatory strategy based on that, and we'll know more about that in the presentation for Dr. Ruben Alvaro. Or which will end up as a pathophysiology, lung atelectasis, ventilation perfusion mismatch, and pulmonary right-left shunt. Cardiovascular effect, we expect arterial vascular resistance or venous vascular resistance. We may have venous pulmonary hypertension, which is actually difficult to diagnose and difficult to treat. When you have arterial vascular resistance, it is easy to give, or relatively easier to give pulmonary vasodilator to work. But if you give pulmonary vasodilator in venous hypertension, might not work, even might worse the situation. It might end up as pathophysiology, pulmonary hypertension, right ventricular dysfunction, or even left ventricular dysfunction, which is more difficult to detect and treat if you are not really aware about this condition might exist, and you're not asking for echo in real time. At the end, if you are relying only on clinical assessment, you have hypoxemia, acidosis, and circulatory failure. So relying only on clinical, you will not get a good idea about what's underlying pathophysiology. You need to investigate by doing serial X-rays, chest ultrasound, and also echocardiography. So now, to make it easy and simple to understand how we deal with these cases, we have three cardiovascular phenotypes and three clinical levels, and they are correlating with each other. So let us discuss first the three cardiovascular phenotypes from the pulmonary vascular resistance point of view. So we may have case really easy to treat and very mild, or even no pulmonary hypertension at all. So we have dominance of the left ventricle, minimal left-right shunt through PFO or PDA, and you have, as I mentioned, dominance of the left ventricle, normal systemic blood flow, and they have normal performance of the heart. As you can see here in this four-chamber view, the left side is more dominant compared to the right side, good contractility, good filling of the heart. There is no significant pulmonary hypertension. Septum is rounded, and the left ventricle is a circle, and the right ventricle is like crescent. So that's a normal relationship. So there's no pulmonary hypertension, very mild, you may have this case. But the most common, in most of the cases, you may have at least moderate pulmonary hypertension when you have high pulmonary vascular resistance, or PPHN, related to high resistance with the dominant right ventricle, as you can see here. You have right-left shunt through the PDA or through vena valley. You may have also normal right ventricular performance. In this category, you don't have any issue with the contractility. It's not that severe, that's associated with RV dysfunction. You have normal systemic blood flow. There is no hypotension. In this case, you have by echo, the right side is dilated compared to the left side. You have tricuspid regurg. You have also from the short axis here, right side is more dilated compared to left side. The septum is now paradoxic or pushed from right to left. and the PDA is right to left. It is suprasystemic pulmonary hypertension, but at the same time, you have good performance of the right ventricle. In most of the cases, it is responsive to pulmonary vasodilator, and typically, the selective pulmonary vasodilator that we recommend is inhaled nitric oxide if you have it, or sildenafil if you don't have nitric oxide. In more severe cases, you may have RV dysfunction due to the right ventricle is getting tired from pushing the blood against high resistance. So you have everything the same like the previous phenotype, but with RV dysfunction, as you can see, poor RV performance or poor contractility, as you can see in the forward chamber view, and also in the short axis view, the right ventricle does not really contract as expected. We add, in this case, merinone or dobutamine on top of nitric oxide. And if there's no good response, we may add prostaglandin in the refractory cases, especially if the PDA is closed or closing. And then if you may have this phenotype, which is not very common, but you may have it and is really tricky to treat if you are not doing echo in real time, and the person doing echo really understand that in some cases you may have LV dysfunction. In this situation, don't use pulmonary vasodilator, don't use nitric oxide or sildenafil when you have LV dysfunction, when you have pulmonary venous hypertension. So we have significant pulmonary stenosis, pulmonary hypertension that's not really easy to diagnose by echo, might need cardiac cath. Systemic hypotension with open PDA. When you have low systemic blood pressure, hypotension, and the PDA is open, the PDA is shunting right to left to maintain the systemic blood flow. It is almost the same like coarctation physiology. So don't give pulmonary vasodilator to drop the pulmonary artery pressure, because at this situation, the systemic blood flow is dependent on the PDA. Congenital heart disease with high pulmonary blood flow, also don't give nitric oxide or pulmonary vasodilator. So pulmonary vasodilator might be contraindicated. It might morph the situation in some conditions. In this condition, you have dominant right ventricle, you have right to left shunt through the PDA, poor ventricular performance, mainly left or low systemic blood flow. So keep that in mind, low systemic blood flow with or without LV dysfunction. You have to improve the blood pressure, improve the LV performance before start of pulmonary vasodilator, especially if the PDA open. The PDA is needed to be right to left in this case. Management, optimize ventilation, like any other case in congenital diaphragmatic hernia. Target saturation is little bit wide, between 85 to 95%. Merinone or dobutamine. You may need to add a medication to help with the systemic resistance, like norepinephrine. Prostaglandin in refractory cases, especially if the PDA is closed or closing. And don't give nitric oxide again. In some situation, you have the congenital diaphragmatic hernia with shock, with systemic shock or systemic vasodilator physiology. When you have low diastolic blood pressure, normal pulse pressure, low systolic pressure as well, because systolic is following diastolic. It is sum of both pulse and diastolic blood pressure. You may have by echo little bit higher stroke volume, tachycardia, and high calculated cardiac output. But when you calculate systemic vascular resistance, it is low. And you have hyperdynamic heart performance. And you can see here the trend of the blood pressure is decreasing by invasive blood pressure. So it is by definition systemic vascular, low systemic vascular resistance with vasodilatory shock. Once you start norepinephrine or vasopressin, you will see the blood pressure improved in this case. It might happen just because of the severity of the disease, or might happen secondary to use of merinone or dobutamine. It might be secondary to the medication that you are using. If you don't have invasive blood pressure, you can still rely on non-invasive frequent measurement of blood pressure. You need to adjust the cuff to measure the blood pressure frequently every 10 to 15 minutes and look at the trend over time. But the standard to use invasive blood pressure through umbilical arterial line or radial arterial line. We have a group of cardiovascular support that you may consider. including vasopressors. So you need to select the medication that makes sense with the underlying physiology. So vasopressors for vasodilatory shock. Don't use vasopressor when you have poor myocardial performance. And the vasopressors could be vasopressin or norepinephrine. Vasopressin needs really intensive care, aware about its use. It cannot be used with a lot of other medication because of incompatibility with most of the medications. It should be used by central line, not peripheral line. It should be used only when sodium is more than 130 millimole because it might induce hyponatremia. Otherwise, use norepinephrine. Inotropes with vasopressor effect, epinephrine, which is can be used in cardiogenic shock when you have both RV dysfunction or poor myocardial performance together with hypotension. So epinephrine can work for both. If you have inotropes, if you have infant with vasoconstrictor physiology, when you have narrow pulse pressure or poor RV performance, use dobutamine or merinone. And also in cardiogenic shock, even when the systemic blood pressure is low, you can use cautiously dobutamine, or you may combine merinone with norepinephrine. And then fluids only if there is hypovolemia. Fluids is not a gift to be given without indication. It is a medication that should be given with indication. So only fluids when there is hypovolemia. And in and out balance should be monitored on daily basis. Steroids can be used in refractory shock, and refractory when you reach any one of these medication with a medium dose. For example, if you use norepinephrine and you reach from 0.05 to 0.1, 0.15, and there's no response, you may send the cortisol level, random cortisol level, or start hydrocortisone. I think you may notice now that there's a missing drug in the list here, which is dopamine. We are not using dopamine in most of the cases in neonates anymore. It is a medication with a lot of side effects, in particular cases with pulmonary hypertension, because it might increase the pulmonary vascular resistance and increase cardiac consumption of oxygen. So if you are at the bedside and you would like to assess for hypoxemia, you need to get all of these indices assessed. Don't rely on your memory. You may have the AI, artificial intelligence calculator. We have that available on our website. And you need just to enter the basic oxygen saturation, basic information, and FiO2, and blood gases, and the calculator will give you an idea about the severity, as you can see here, moderate or severe hypoxemia based on each index. You need to rely on oxygen saturation histograms. It's very important and reliable. AA gradient oxygenation index if you have arterial blood gas, oxygen saturation index if you don't have arterial blood gas, saturation FiO2 ratio. The lower the number, the ratio is the higher the severity of hypoxemia. VQ ratio can be calculated non-invasively through non-invasive calculator available also on our website. So don't just look at the saturation or FiO2 in one time. You need to collect data about oxygen indices and get a good idea about the severity of hypoxemia. And then the classification of congenital phlegmatic hernia can be mild, moderate, severe, based on what we said. So mild with the pulmonary management, usually the infant might benefit from conventional ventilation. All oxygen indices are within mild values based on the previous slide. And OI usually less than 10. Cardiovascular support, usually subsystemic pulmonary hypertension or mild. Normal systemic blood pressure, stable hemodynamics. Maximum might require nitric oxide for short period of time or no support needed for cardiovascular system, and ready for surgery at any time after birth with good prognosis. Moderate cases, the moderate cases usually require moderate and severe high frequency ventilation, either oscillator or high frequency jet ventilation that we are using in our unit. And then we are using MAP between 10 to 14, OI usually 10 to 15 as well. Most oxygen indices are within the moderate values. Cardiovascular support, nitric oxide in most of the cases. and might be partial response. You might need to add sildenafil in some cases. Ready for surgery after stabilization might take few days. Pre-operative hemodynamics assessment by expert in hemodynamics. Good prognosis with appropriate care. So in mild congenital rheumatic hernia, the prognosis is almost 100% recovery. Moderate cases is around 90% survival. Severe cases about 70%. In severe cases, we expect high setting, high frequency, or pressure more than 15, oxygen indices on the severe range, cardiovascular support, usually suprasystemic pulmonary hypertension, and probably RV dysfunction, usually require nitric oxide plus sildenafil sometimes, plus medication like Merinon or dobutamine, whose expected unstable hemodynamics might also require vasopressor like norepinephrine. Requires a trained hemodynamics team, stabilization before surgery on multiple cardiovascular medication. Sometimes you need to send for surgery on cardiovascular support or nitric oxide. This category might require ECMO in rare cases, and the prognosis is expected to be poor. We are talking about 50 to 70% survival. This is the Canadian Pediatric Society position statement and was summarized in this published article, was published just last year. It summarizes the steps of evaluation and the framework of practice based on the consensus opinion from the hemodynamics expert from Canada and from US. In case of hypoxia, you have to be sure that it is not related to any other reason other than pulmonary hypertension. Could be pneumothorax, could be other thing. So it is confirmed by echocardiography as pulmonary hypertension. Then you may consider nitric oxide. If no response or partial response, check for blood pressure. And if the blood pressure is low systemic blood pressure, if the answer is no, there is no, the blood pressure is normal, then you can use Merinon. Merinon is a strong vasodilator. Dobutamine or prostaglandin, if unresponsive to either Merinon or dobutamine. Don't use Merinon dobutamine at the same time because the hypotension would be really significant. But if there is hypotension with RV dysfunction, then you can use dobutamine or epinephrine plus minus prostaglandin. If there is no RV dysfunction or normal RV performance, then you can use vasopressin or norepinephrine with or without hydrocortisone. So this is a framework or the algorithm that we are using in our unit and most of the units in Canada. Just to highlight some considerations, don't use dobutamine and Merinon together. Otherwise, the hypotension will be significantly expected. If blood pressure dropped after start of Merinon or dobutamine, you can add norepinephrine. With high pulmonary vascular resistance, dopamine is better avoided or better avoided at all. Is not a medication that is not recommended as a medication for cardiovascular support in ICU. Don't use pulmonary vasodilator in presence of LV dysfunction, because especially if the PDA is open, because the PDA in this situation will be supporting the systemic circulation, the same like coarctation physiology. And if you are not sure about the anatomy, or you cannot exclude 100% any congenital heart disease like abnormal pulmonary venous return, you may ask for CT angio for assessment of the detailed assessment of the anatomy, especially if you are going into the direction of ECMO support. So, and we have now the preoperative case. I have 3 quick case scenarios to share with you. The first one is mild case, very easy to manage. A term infant, congenital rheumatic hernia, actually undetected antenatally, and then after birth, stayed in the well baby unit, 8 hours of age, detected with respiratory distress. You can see the X-ray. It started on conventional ventilation, PEEP of 7, and volume of 3.5 ml per kg, FiO2 70%. There is mild pulmonary hypertension, but it was subsystemic. The interventions based after the echo and X-ray was to decompress this intestine, muscle relaxant infusion, then boluses, and good size of ET tube without leak, then cautious recruitment of the lung. After recruitment of the lung, the PEEP increased to 9, and then volume optimized to 4 ml per kg. Oxygenation index decreased from 10 to 5 without need for any pulmonary vasodilators. Just to optimize the lung inflation was enough to get this infant ready for surgery. So we have another case, moderate case, diagnosed antenatally. And you can see here the lung is barely seen in the X-ray. Initial high frequency ventilation in any moderate or severe. The default respiratory support is high frequency ventilation. We started PIB of 29, PIB of 7, FiO2 60%. Anything more than 50% FiO2 is high. OI is more than is 11, and the saturation FiO2 ratio 155. The lower the number, the higher the severity, and pre-post ductal saturation difference 10%. So the impression from the echocardiography, as you can see, suprasystemic pulmonary hypertension did not improve after nitric oxide. That's why they added Merinone. And then the Merinone did not make a big difference. Only the blood pressure dropped. And systemic vascular resistance was 65 millimeter mercury per liter per kg per minute, which is low. The acceptable systemic vascular resistance should be between 150 to 250 millimeter mercury per liter per kg per minute. So that's consistent with vasodilatory physiology, typically because of Merinone. It did not happen because of the severity itself of the disease. So norepinephrine was started. And then we'll continue with the same case with after good sedation, muscle relaxant, lung recruitment, which is the most important step in this situation. PIP increased to 35, 33, PEEP increased to 9. You can see some improvement in lung inflation. And then initially in high frequency jet ventilation, as you can see here. And then Merinone was off before surgery, and also norepinephrine. So typically, it did not require Merinone, and norepinephrine started because of the side effect, vasodilator side effect of Merinone. So both of them discontinued and just continued nitric oxide unit surgery. The infant tolerated surgery very well. And 3 days post-surgery, you can see the lung inflation is perfect. Now the heart performance is very good, and the PFO shunt is left-right. And you can see the right ventricle is smaller compared to left ventricle. So resolved pulmonary hypertension and of nitric oxide. And all of these echoes, I have to highlight that were done by Dr. Hanifi Soima. The last case is a severe case, 36-weeker with congenital phlegmatic hernia diagnosed antenatally. You can see significant huge dilatation of the right ventricle with significant lung collapse, initially in high frequency jet ventilation, PIB of 26, BEEP of 7, FiO2 of 90%, OI of 16, and suprasystemic pulmonary hypertension was dilated, impaired RV performance. Started on nitric oxide with no response, and then added Merinone, increased up to 0.75, and then added sildenafil. Blood pressure dropped, as expected, with systemic vascular resistance only 67. So consistent with vasodilatory physiology, and that's why the norepinephrine was started. So that could be because of the side effects of Merinone together with sildenafil. And then interventions to optimize everything, decompress the intestine, and then muscle relaxant, started infusion, then boluses, good sedation. This is very important step to keep the intestine deflated. Lung recruitment, PIB increased, PEEP increased to 9, and sildenafil maintained on sildenafil, and maintained the duct open with prostaglandin. In this situation, the Merinone discontinued, and norepinephrine as well, continued on nitric oxide only, and sildenafil. Prostaglandin also discontinued. And the infant ready for surgery in just a few days. So the surgery went smoothly without any issue. And just to summarize everything, in congenital phragmatic hernia, you have to have a checklist, and you have to be ready with everything, equipment and team and anticipation. Anticipation of the severity should be based on antenatal ultrasound, oxygen indices, cardiovascular assessment, chest X-ray plus chest or lung ultrasound. And the team, we consider minimum of 2 physicians, 2 respiratory therapists, 3 nurses, pharmacists, and expert neonatologists in hemodynamics. The team should be ready in L&D for any unexpected scenario. So in mild cases, just in summary, conventional mechanical ventilation might need pulmonary vasodilator, mild sedation, usually morphine, ready for surgery soon after birth. Moderate cases require high-frequency ventilation, at least 1 pulmonary vasodilator. Moderate sedation, morphine, midazolam, plus minus muscle relaxant, ready for surgery once stable in few days. In severe cases, definitely high-frequency ventilation, at least 1 pulmonary vasodilator. We need second pulmonary vasodilator and inotrope with or without vasopressor, plus minus prostaglandin. That's why involvement of expert in hemodynamics is extremely important. Or pediatric cardiologist, if you don't have expert in hemodynamics, may require ECMO, aggressive sedation and muscle relaxation, ready for surgery once stable, which might take maybe 1 week or more. So sincere advice, don't rely on your memory or your mood only for making decisions. Use checklists for sophisticated decisions. Always I have checklist available in my iPad or even written printed before making decisions. We don't rely on memories that might make a lot of unnecessary errors. You can use smart calculators and artificial intelligence now available on a lot of websites, including our website. 3 main conclusions. Management of congenital phragmatic hernia requires a trained team on intensive respiratory and hemodynamic support. Cardiovascular support is best to be managed by a neonatologist trained on hemodynamics. Proper lung recruitment is always a priority. So remember, in the second and third case was unnecessary use of Merinon and too much vasodilator, and the situation improved only after appropriate lung recruitment, which is the most important step. And we will hear more about that in the presentation for Dr. Ruben Alvaro. Thank you.
Thank you very much, Dr. Yasser, for this very excellent and dedicated presentation. So the question I have, I don't know if we have a time, but maybe 1 question or 2 questions. The first one is, like sometimes we have to use many medications because some of them are not very effective. So what is your advice? Like stop one and then try the other one, or just add the second one and see how everything is going? So what do you do in your practice?
Yeah, thank you very much. This is a very important question. In a lot of situations, the decompensation, deterioration happened because of the side effects of medication that you are using. And using combination of cardiovascular medication might cause more issues, more than help, more than support. And as I realized from the case scenarios, in most of the cases, we used a second medication like Merinon or sildenafil because of the lung was not optimized and the hypoxemia was significant. So the most important step to be sure the lung optimized. You can rely on oxygen indices. You can recruit the lung cautiously, increasing PEEP gradually, relying on maybe X-ray, lung ultrasound, stepwise. Get your maximum and be sure that you are not exceeding the appropriate lung inflation. Otherwise, the infant might develop pneumothorax and might be a disaster. So optimize the lung inflation before considering any medication to help with pulmonary hypertension. If you are using medication like Merinon or dobutamine to improve RV dysfunction or performance, that should be guided by expert person like you in hemodynamics. So if you are exceeding one medication or one support for pulmonary as pulmonary vasodilator like nitric oxide or sildenafil, and you need to use another medication, then it's better to consult someone expert in hemodynamics before adding medication over medication without reasonable response. And once you get the response optimized, then you can consider to wean the medication or discontinue. It's better to send the infant for surgery with the minimum support. If you send the infant with too much support, that might cause a lot of issues to the anesthesia and the surgeon. And I see my friend Giuseppe is smiling because I think that's one of the issues that might happen when you send congenital rheumatic hernia or any other infant with too much support. So usually they come to the unit, and once they see a lot of medications listed, they know that this infant is not ready. We cannot, it's risky to send the infant for surgery at this time. Better to wait. So it is sometimes in your hand, and some of these medications just one and the other one just to treat the side effect of the other. So we started Merinon unnecessarily, the infant developed hypotension, and then add norepinephrine because of hypotension happen, and just have multiple medications to balance the side effects, and all of them probably they are not really necessary or needed, and you need just to maybe try to discontinue them. Otherwise, you will postpone surgery and you will get the infant probably compromised more.
Okay, there is one case, actually, no, one question here. It is actually the same problem, Egypt and Turkey. So there is no IV sildenafil. What is the function of oral sildenafil? Is there any role of oral sildenafil in any part of your management in these cases?
Yeah, typically in sick cases, we are using infusion because they are not in oral feeding yet. Probably is not very safe.